Welcome to mudaliar and menon clinical obstetric lecture series. So the topic that we are going to discuss here is chapter 25, fetal growth restriction. So let's dive into this topic. So first, coming to the definition, define FGR or IUGR, fetal growth restriction, which was previously known as intrauterine growth restriction, is a condition wherein the fetus fails to reach its genetic growth. The fetus fails to reach its genetic growth potential and consequently is at an increased risk of perinatal morbidity and mortality. So fetal growth restriction, or previously known as IUGR, is a condition wherein the fetus fails to reach its genetic growth potential and consequently is at an increased risk of perinatal morbidity and mortality. This may result in a fetus that is small for gestational age. It is estimated that 3 to 10% of infants are growth restricted. Now the main definitions. What is AGA, what is LGA, and what is SGA? AGA means appropriate for gestational age. So fetuses whose weight is between 10th and 90th percentile for their gestational age is known as average for gestational age fetuses. So that is AGA. Normally all the average fetuses will be weighing between 10th and 90th percentile. Okay, now if it is more than 90th percentile, it is large for gestational age. If it is less than 10th percentile, it is small for gestational age. So fetuses whose weight is above 90th percentile for the gestational age are known as large for gestational age. Fetuses whose weight is below 10th percentile for gestational age is known as small for gestational age. Small for gestational age includes fetuses that are genetically small. Okay, so if the fetuses are genetically small, that is a normal small fetus. Okay, small for gestational age can be a constitutional one. Small for gestational age can be divided into two. One is there is a constitutional delay. Constitutional delay means genetically they are going to be small. That is, it is a normal small fetus, or it can be FGR. Okay, fetal growth restriction. Now the most common definition of SGA is estimated fetal weight or abdominal circumference. Estimated fetal weight or abdominal circumference below the 10th percentile for the gestational age. So now let's look at the growth pattern of a normal fetus. So any normal fetus, the growth pattern comprises of 3 phases. Phase 1, phase 2 and phase 3. In phase 1 there is going to be cellular hyperplasia phase. So phase 1 there is it is a cellular hyperplasia. What is hyperplasia? Increase in the number of cells. Hyperplasia. So there is a cellular hyperplasia and this lasts for the first 16 weeks of gestation. First 16 weeks. Okay, first 16 weeks of gestation is going to be your cellular hyperplasia phase. Next, coming to phase 2. Phase 2 is a phase of concomitant hyperplasia and hypertrophy and occurs between the weeks of 16 and 32 weeks of gestation. So what is phase 2? Phase 2 is a phase of concomitant. Both cellular hyperplasia also will be there. Along with hyperplasia, hypertrophy, increase in the size of cells, hypertrophy also will be there. So both hyperplasia and hypertrophy will be there, and this occurs between 16 to 32 weeks of gestation. That is phase 2. Next, coming to phase 3. In phase 3, what we have? In phase 3, there is only cellular hypertrophy. So only cellular hypertrophy phases. Phase 3. Only cellular hypertrophy will be there, which occurs between the weeks of 32 and term. So this is from 32 weeks up till term. Okay, it is going to be phase 3, that is cellular hypertrophy. So phase 1, the first 16 weeks, cellular hyperplasia. Phase 2, hyperplasia plus hypertrophy between 16 to 32 weeks. Phase 3, cellular hypertrophy, that is from 32 weeks up till term. Now, what are the effects of fetal growth restriction? So fetal growth restriction has certain effects, right? So what are the effects of fetal growth restriction? So the main effects are hypoglycemia, hypothermia, thrombocytopenia, polycythemia, hyperbilirubinemia, hypocalcemia, perinatal asphyxia, and neurodevelopmental delay. So fetal growth restriction effects are mostly hypo. I will finish off all the hypo first. Hypoglycemia, hypothermia, thrombocytopenia, hypocalcemia, and then two things are more, that is polycythemia and hyperbilirubinemia, and then we have perinatal asphyxia as well as neurodevelopmental delay. Now moving on to the types of fetal growth restriction. So there are two types of FGR. One is the symmetrical FGR, another one is the asymmetrical FGR. So the incidence of asymmetrical FGR is more common, around 70 to 80%, whereas symmetrical FGR is less common. So first, moving on to the first characteristic, that is growth inhibition. In symmetrical FGR, growth inhibition occurs early. Okay, the growth inhibition is going to be much earlier in pregnancy. Okay, very early in pregnancy, in the hyperplastic stage itself. That is phase 1 itself. So in symmetrical IUGR, the growth inhibition will be in a very much earlier phase of pregnancy. That is the phase 1. Phase 1, that is hyperplastic stage. Whereas in asymmetrical FGR, it occurs late. It occurs late in pregnancy, around say 28 weeks and after, especially in the phase 3, that is hypertrophic stage. Hypertrophic stage will definitely occur only after 28 weeks. Then the number of cells. The number of cells is going to be reduced in symmetrical FGR. Okay, see hyperplasia. What is hyperplasia? Increase in the number of cells. If this is inhibited, then there will be reduced number of cells. So number of cells will be reduced in symmetrical FGR. Whereas in asymmetrical FGR, there is going to be a near normal number of cells. The number of cells will be almost normal, but the size alone will be altering, because asymmetrical FGR only affects the or inhibits the hypertrophic stage. Therefore, the number of cells will be near normal, but it will be smaller in size. Next, moving on to growth parameters. In growth parameters, head circumference divided by abdominal circumference ratio and weight divided by length ratio are going to be all below 10th percentile. Whereas in asymmetrical FGR, so the ratios will be almost below 10th percentile, and also in symmetrical FGR it will be like the ratio will be normal. But in an asymmetrical FGR, there is going to be a brain sparing effect. What is brain sparing effect? So the uteroplacental circulation is going to be compromised. Therefore, to prevent fetal hypoxia in that condition where the placental circulation is compromised, The blood will be diffused and shifted only to the brain first, to the vital organs first, and then only to the rest. That is known as brain sparing effect. So, and hence the head circumference divided by abdominal circumference is going to be altered. So the head will be very big and the body size will be small because of brain sparing effect in asymmetrical FGR. Then ponderal index. What is ponderal index? Ponderal index is given by weight in grams divided by length in centimeter cube. Weight in gram divided by length in centimeter cube. It will be normal in symmetrical FGR, but it is low in asymmetrical FGR. Now, symmetrical FGR is associated with early intrauterine infection like the torch infections, toxoplasmosis, rubella, cytomegalovirus, chromosomal abnormalities, anemia, and maternal substance abuse. Whereas asymmetrical FGR is associated with mainly high blood pressure condition like preeclampsia, pregnancy-induced hypertension, severe malnutrition, genetic mutation, Ehlers-Danlos syndrome. High blood pressure, severe malnutrition, genetic mutation, Ehlers-Danlos syndrome. These are the associations with asymmetrical FGR. Now moving on to the baby size. As I already mentioned, because in the growth parameter, this in symmetrical FGR, the word says symmetrical, that is, it is uniformly small. But in asymmetrical FGR, the head is going to be normal and the rest of the body will be thin and small. Okay, the head will be normal, but the rest of the body is thin and small because of the brain sparing effect. So, intermediate FGR. What is intermediate FGR? Intermediate FGR, in this type of FGR, both the types of growth restriction are seen. Okay, in intermediate FGR, it is going to be symmetrical plus asymmetrical. Both the types of fetal growth restriction is seen in intermediate FGR. It accounts for 5 to 10% of cases of IUGR, and FGR is also going to be classified as early onset or late onset. Early onset FGR or a late onset FGR. What do you mean by early onset FGR? That is before 32 weeks. What is late onset FGR? Greater than or equal to 32 weeks. So any FGR before 32 weeks is early onset, and any FGR that is occurring beyond or equal to 32 weeks is late onset. Moving on to the etiology for FGR. So etiology of FGR can be again maternal factors, fetal factors, and placental factors. First, moving on to the maternal factors. Maternal nutrition plays a very important role in FGR. So maternal nutrition, substance abuse and cigarette smoking, uteroplacental insufficiency, chronic maternal hypoxia, maternal medication like anticonvulsant, anticoagulant, folic acid antagonist and anti-neoplastic agent, uterine factors like fibroid complicating pregnancy and congenital malformation, socio-demographic variable, obstetric history. The risk of recurrence of FGR is nearly 30%. Raised alpha-fetoprotein levels. So these are the maternal factors. Now moving on to the fetal factors. In fetal factors, we have chromosomal abnormalities like autosomal trisomy 18, trisomy 21 and all, and congenital malformations, multiple gestation, pregnancy followed especially by assisted reproductive technique, fetal infections, and third we have placental causes like placenta previa, circumvallate placenta, placental infarction, chorioangioma of placenta, abnormal cord insertion. These are the three factors, maternal, fetal, placental factors respectively, contributing to fetal growth restriction. Now coming to the diagnosis of fetal growth restriction. So there are certain clinical parameters to suspect growth restriction of the fetus. First is the static weight or weight loss during pregnancy. So if there is a static weight or weight loss during pregnancy, reduced Leica volume by clinical examination, height of the uterus by abdominal palpation, and symphysiofundal height measurement. So these are the four clinical parameters to suspect growth restriction of the fetus. Weight loss, reduced Leica volume, height of the uterus by abdominal palpation, and symphysiofundal height. This is the 10th percentile. This is the 90th percentile. In between 10th and 90th is the average for gestational age. Below 10th is your small for gestational age. Above 90th is the large for gestational age. Just where we are plotting the symphysiofundal height as with the gestational week, symphysiofundal height in the y-axis and gestational age in the x-axis. This is known as gravidogram. So this graph is known as gravidogram. Now what are the fetal biometric measurements by ultrasound? So the fetal biometric measurements by ultrasound is the first, diagnosis and evaluation for fetal growth restriction in low risk patients. A routine growth scan and estimated fetal weight at 32 to 34 weeks of gestation is done. So growth scan is very important investigation for diagnosis of FGR. In case of high risk patients, for all pregnancies with high risk factors, serial biometric assessment of the fetus is done from 26 to 28 weeks onwards. You will be taking head circumference, the biparietal diameter, the abdominal circumference, which is the most sensitive parameter. In MCQ, if they ask which is the most sensitive parameter to assess fetal growth restriction, it is the abdominal circumference. Then we have femur length, estimated fetal weight, head circumference divided by abdominal circumference ratio, femur length divided by abdominal circumference ratio. So what all parameters we have or biometric assessment we have for high risk patients? Head circumference, BPD, abdominal circumference, femur length, estimated fetal weight, head circumference divided by abdominal circumference ratio, femur length divided by abdominal circumference ratio. So in a fetus with a normal growth, that is between 10th and 90th percentile, the interval growth will be maintained. Whereas in a small for gestational age fetus, it is going to be below 10th percentile and the interval growth is also maintained. In a growth restricted fetus, the interval growth may be reduced. So the interval growth will be reduced in a FGR. So amniotic fluid volume measurement. If you are doing the amniotic fluid volume measurement, you can find oligohydramnios. Next investigation is for diagnosis is Doppler velocimetry. In Doppler velocimetry, an abnormal umbilical artery Doppler velocimetry, okay, an abnormal. So the umbilical artery Doppler velocimetry, if you do, it's going to be abnormal, as characterized by a increased systolic diastolic ratio. There will be increased systolic diastolic ratio and absent or reverse end diastolic absent or a reverse end diastolic flow, okay, absent end diastolic flow or a reverse end diastolic flow, okay, and is going to be correlated with a poor perinatal outcome. This is the finding in abnormal umbilical, in the umbilical artery Doppler velocimetry, which is abnormal. Then you have your amniotic fluid volume measurement. Amniotic fluid volume measurement as well as the Doppler studies are more valuable for the assessment of well-being of the fetus. So in this we can see the algorithm of the management of intrauterine growth retardation. So this is the algorithm. Okay, first if we have to see the height of uterus. Height of uterus, if it is less than or equal to 4 weeks gestation than estimated gestation. Okay, if the height of uterus is going to be less than or equal to 4 weeks than the estimated gestation, we need to consider IUGR. Okay, and we need to consider IUGR after recalculating the gestation. And then we need to confirm IUGR by using an ultrasound as well as a Doppler velocimetry. So we have to confirm this diagnosis of IUGR by using a ultrasound and a Doppler velocimetry. Then management when the diagnosis is going to be confirmed. So when the diagnosis is confirmed, then we are going to start our management. So the management is based on the gestation. We need to see if the gestation is more than or equal to 37 weeks or the gestation is less than 37 weeks. If at all the gestation is more than or equal to 37 weeks, definitely we need to deliver the patient. Now, if the scenario is that the gestation is less than 37 weeks, then we need to monitor the fetal growth as well as we need to monitor the fetal well-being very closely. And then we need to look for the fetal well-being. Clinically, how are we going to assess the fetal well-being? By the DFMC, daily fetal movement count. Then fetal surveillance. In fetal surveillance, you have NST. NST we must do it twice weekly or on alternate days in a severe IUGR. If abnormal, we need to do, if NST is abnormal, then we need to do a modified biophysical profile. So what is modified biophysical profile? Modified biophysical profile is NST plus AFI, amniotic fluid index. And then if abnormal, if this modified biophysical profile is abnormal, then we need to do a Doppler velocimetry. Just Doppler velocimetry is to determine the degree of asphyxia. So why are we doing Doppler velocimetry again? We have to look for the and determine the degree of asphyxia. Now, if the fetus grows, okay, if the fetus grows and is going to be well, then we need to deliver at 37 weeks. If the fetus shows signs of asphyxia, if suppose the fetus will show some certain signs of asphyxia, we need to deliver in a setting where neonatal care is available. So whenever the fetus shows signs of asphyxia, definitely a neonatal care should be available during delivery. Now management. Management is based on gestational age at diagnosis. I told you already, gestational age is based, that is less than 37 weeks what you should do and more than 37 weeks what you should do. If more than 37 weeks, definitely we should deliver. If less than 37 weeks, then we need to look and assess the fetal well-being and growth. Then the estimated fetal weight. Then the management is based on underlying etiology as well as associated morbidity as well as the severity of FGR. Now first, what is conservative management? So suppose you say if the fetus is less than 37 weeks of gestation and if there is no maternal or fetal contradiction, okay, the fetus is less than 37 weeks of gestation, there is no any kind of maternal or fetal contraindication, conservative management can be undertaken. So what are the general measures? First, we need to give rest for the patient. Then maternal oxygen therapy is required. After maternal oxygen therapy, low dose aspirin, that is 1 to 2 milligram per kg per day. Beta mimetics, heparin, calcium channel blockers can be given. Maternal nutrition therapy is very must. Treatment of associated maternal conditions. monitoring the fetal growth and well-being by DFMC, daily fetal movement count, NST, and biophysical profile. And the last one is Doppler velocimetry. So these are the general measures that we'll be doing if the fetus is going to be less than 37 weeks of gestation. Now, biophysical profile. Biophysical profile indeed is a short note in exams. So the score. Okay, so first, what are the components of biophysical profile? NST, non-stress test, fetal breathing, fetal movement, fetal tone, and AFI, amniotic fluid volume. Okay, non-stress test. Biophysical profile components are non-stress test, fetal breathing, fetal movement, fetal tone, and amniotic fluid volume. So score 2 is a reactive one. If non-stress test, reactive score 2, non-reactive score 0. Fetal breathing score 2 means one or more episodes of rhythmic breathing lasting 30 seconds or more within 30 minutes. Whereas score 0, less than 30 seconds of breathing in 30 minutes. Fetal movement, 3 or more body or limb movements in 30 minutes. Score 0 means 2 or less movements within 30 minutes. Fetal tone, 1 or more episodes of movements or extension of a fetal extremity with return to flexion or closing or opening of hand. No extension or flexion, score 0. Amniotic fluid volume, a single vertical pocket more than 2 cm, score 2. A largest single pocket of 2 cm or less is score 0. Now, moving on to obstetric intervention. Say if the fetal growth is satisfactory and the fetal surveillance test indicates that the fetus is not in distress, the pregnancy is allowed to continue until 37 weeks. However, if the fetus is not in a good condition, early delivery is indicated, and management should be in a place where there are adequate facilities for cesarean and neonatal care and experienced personnel are available. Now, management of late onset growth restriction, that is pregnancy 37 weeks or more with FGR, delivery of fetus must be done. As I already told you, more than 37 weeks means you need to deliver the fetus. So FGR before 37 weeks, biophysical profile is performed 1 to 2 times a week and umbilical artery Doppler 1 to 3 times a week. Corticosteroids is given in fetuses, especially less than 36 weeks of gestation for lung maturation. Magnesium sulfate prophylaxis for neuroprotection in growth restricted fetuses is given. And immediate delivery, that is arrest of growth over a 2 to 4 week interval, spontaneous repeated persistent unprovoked fetal heart deceleration, altered biophysical profile, and maternal indication. Mode of delivery. So in case of mild IUGR, where the fetus is not under stress, labor can be induced with continuous CTG as well as vaginal delivery is attempted. But in a fetus with severe growth restriction, then cesarean section with a good neonatal backup would be improving the chances of fetal survival. Now, what are the indications of cesarean section in fetal growth restriction? So first is severe fetal compromise at any period of gestation, fetal compromise or distress diagnosed in labor, other obstetric indications such as malpresentations. Now, management of early onset growth restriction. How are we going to do the management of early onset growth restriction? First is an asymmetrical FGR is diagnosed before 32 weeks of gestation. A symmetrical growth restriction is diagnosed at any gestational age. In absence of maternal systemic disease or risk factor, one should consider the congenital infection and chromosomal and congenital abnormalities as possible cause. The presence of intracranial and liver calcification indicates fetal infection. The rest of management is similar to the late onset fetal growth restriction. Prevention. How are we going to prevent FGR? So women should be educated regarding adverse effects of alcohol consumption and smoking. Teenage pregnancy should be prevented. Pre-pregnancy counseling should be instituted to identify the risk factors based on previous obstetric history and family and medical history. Those diagnosed with APLA, antiphospholipid and antibody syndrome, should be started on low-dose aspirin prior to pregnancy. Women who are at a risk of developing FGR should be identified during the first antenatal visit, and at risk women should be carefully monitored during the antenatal period. So what is this APLS? APLS stands for antiphospholipid syndrome. So this antiphospholipid syndrome is an immunological condition that is characterized by occurrence of venous or arterial thrombosis. Okay, what is a APLS first? Antiphospholipid syndrome is basically an immunological condition. And this immunological condition, how are we characterizing? It is characterized by the occurrence of a venous or arterial thrombosis or a specific pregnancy complication in the presence of laboratory evidence of antiphospholipid antibodies. So APLA, that is antiphospholipid antibody evidence, will be there in APS. Pregnancy related complications associated with APLA are recurrent miscarriages, unexplained second and third trimester losses, unexplained fetal growth restriction, intrauterine death, severe early onset eclampsia, abruption and postpartum thrombosis. Okay, all of these are pregnancy related complications that are associated with APLA syndrome: miscarriage, abortion, second and third trimester loss, unexplained fetal growth restriction, intrauterine death, severe early onset eclampsia, abruption, postpartum thrombosis. All are complications of APS. Now the clinical criteria to diagnose antiphospholipid syndrome is first one or more unexplained fetal death of morphologically normal fetus of gestation more than 10 weeks is given. Then, so what is the first criteria? There must be unexplained fetal death, okay, of a morphologically normal fetus of gestation more than 10 weeks. And preterm delivery. So preterm delivery of morphologically normal infant before 34 weeks of gestation due to severe preeclampsia, eclampsia or features consistent with placental insufficiency. 3 or more unexplained consecutive spontaneous pregnancy losses less than 10 weeks of gestation after the exclusion of maternal anatomic and hormonal abnormality and paternal and maternal chromosomal abnormality. Unexplained arterial and venous thrombosis. Unexplained arterial and venous thrombosis in pregnancy or puerperium. Now, what is the diagnostic evaluation of antiphospholipid syndrome? So, first is going to be IgG. IgG and IgM anti-cardiolipin antibodies. Very important, anti-cardiolipin antibodies. So, IgG and IgM of anti-cardiolipin antibodies, and IgG and IgM anti-beta 2 glycoprotein antibodies. Okay, so first is IgG and IgM anti-cardiolipin antibodies, then IgG and IgM anti-beta 2 glycoprotein antibodies. Lupus anticoagulant testing, and these tests should be done twice, 6 to 8 weeks apart. What is the management? The management of antiphospholipid syndrome is to start with low dose aspirin, that is around 50 to 100 milligram per day, started when the conception is attempted. Then a prophylactic dose of low molecular weight heparin or an unfractionated heparin is given on confirmation of intrauterine pregnancy. Close antenatal fetal surveillance is done. Delivery is scheduled around 39 weeks of gestation or earlier depending on the fetal surveillance test. Heparin should be discontinued before labor and delivery to minimize the delivery related bleeding. Low dose aspirin can be stopped at any time after 36 weeks of gestation and ideally should be stopped 7 to 10 days before delivery. Prevention measures should be taken in the postpartum period also to prevent a deep vein thrombosis. And women with antiphospholipid antibody should avoid estrogen containing hormonal contraceptives. So we have come to the end of this chapter. So if this video was useful, do like, subscribe and share this channel. And to watch the other lectures on mudaliar and menon series, you please do subscribe this channel. Thank you.